And hi, everybody. It's so nice to see you guys. I love that all these cameras are on. So even though we've been apart for, is it 47 weeks, 48 weeks coming up here, I think, I don't feel like it's been a year since we've had a chance to see each other. At least, at least we have Zoom. It's not perfect, but here we are. So, okay, well, people will continue to join us, and thanks to Peter and Gordon, we've got everything taken care of here as far as people joining us without interrupting anything. I want to say hi. I know most of you, but I know this was advertised all over the place, so we may have some visitors with us today, and everyone is welcome. The session will be recorded as well. If you find it fascinating and want to pass it along to friends and family, you're welcome to do that. I'm Rabbi Jessica Graf, the Senior Rabbi at Congregation Shereth Israel, and I'm delighted to have you all with us for what will definitely be a fascinating conversation. These From the Front Lines conversations started way back at the beginning of the pandemic, when we realized that it was very difficult to get accurate news, real information about this confusing time out in the world. And we wanted to be able to look at the experts from within our larger community who are working so hard to help to make the situation better, to bring about incredible scientific discovery and healing and support for all of us and for the world by extension. And we've been so lucky to have wonderful experts with us throughout this process. Today, we're particularly lucky. And as I just said to Dr. Fuchs a minute ago, he's a very busy guy at all times. But in the middle of a pandemic, the guy who's running the response to the pandemic is probably the busiest guy in San Francisco. We're so grateful to you for joining us today. I want to share a short bio about our guest speaker today. Dr. Jonathan Fuchs is the director of the Center for Learning and Innovation at the San Francisco Department of Public Health and clinical professor of medicine at UCSF. In March of last year, Dr. Fuchs was activated to our city's public health response to COVID-19 as the lead of the containment branch, which launched some of the nation's first isolation and quarantine hotels for people experiencing homelessness and those living in dense congregate settings who needed support for suspected or confirmed COVID-19. Last July, he was asked to lead the city's testing strategy, and in mid-January, just recently, he was charged to create a new network of neighborhood vaccine access sites serving communities hardest hit by the pandemic. So Dr. Fuchs is a leader in medicine in our city, in the Jewish community, and I thank you tremendously for being with us. You will be in conversation with Dr. Jonathan Graf, our immediately resident in my office, doctor, and Rebbitzin. I'll turn it over to him. He's been a wonderful leader of these conversations, bringing us all kinds of topics. So I know many of you have questions, some you've submitted and some you may submit now about all kinds of things relating to the vaccine. Our doctors, Jonathan, will talk about lots of things, but may not get to all of the questions, and I'll be happy to forward questions afterwards if they focus on other things besides the many questions that I'm sure will come in. So without further ado, Dr. Jonathan Graf.
Well, thanks, Rabbi Jessica. I think that was a fantastic introduction that you gave, but you left one small little piece out that's not in the bio that I want to start with as well. And that is that part of what gives me great nachas and joy in actually doing this is that, I don't know how many of you know, but Jonathan was a residency classmate of mine now more than 20 years ago here at UCSF. And exactly, how old are we really? I don't look quite as good as you, Jonathan, but it's one of the really fun things about our particular class is having the chance over the last 20 years to see what our friends, all of us who experienced the life-changing training that we sort of went through while we were residents here, what we've all ended up doing with our lives. And Jonathan has stayed near and dear and close to San Francisco and to UCSF, and went off into sort of the epidemiology world and the public health and public action kind of world, working with the city and the AIDS research group that the DPH had sort of assembled. And it's sort of along those lines that not only have you made it your name for yourself, I think in that regard, Jonathan, and certainly I've followed your career with over the years, both personally, but also a little bit from afar with a lot of interest and respect and just real pride. But from a practical sense, and I want to start by asking you some questions in this regard. San Francisco has done remarkably well compared to other urban centers in regards to its response, at least to date, to the COVID-19 epidemic. There are a lot of reasons why that may or may not be. We are the second densest city in the US, which certainly puts us at risk in a pandemic like this for both rapid spread and poor outcomes. And yet, by a lot of different metrics and measures, we stack up, if not near the top, at the top compared to other cities, both in terms of our response and what our sort of overall outcomes have been, whether we look at hospitalizations, mortality, number of COVID-19 infections and such. Some people, people have been looking for reasons why this may be, but some people have hypothesized, and I buy into this. We already have a very sophisticated public health infrastructure that's been in the city for many, many, many years. We have a great relationship between our major academic medical center in the city and the Department of Public Health and the public health hospital here. That goes back more than a century. But certainly since the AIDS epidemic in the 1980s, we've built, and certainly, and the not just AIDS, but the infections that go along with it, tuberculosis and things like that. We've set up a public health infectious disease infrastructure and epidemic infrastructure here that certainly was ahead of the curve when it came to dealing with the AIDS epidemic. I think it's very interesting that the group you work with, you in particular, were mobilized to this effort to deal with COVID-19, sort of that in-house expertise that could translate so readily from HIV to COVID-19, two completely different infections. Can you talk a little bit about that and about some of the infrastructure that has existed in the past and how some of the novel ideas that have sort of been put into place regarding our COVID-19 response?
Absolutely. So first, I just want to say this is such an honor for me, Rabbi Graf. Thank you for having me. And Jonathan, I mean, this is just such a privilege and a joy to spend time with you and with the entire Sharet Israel community. So thank you for having me. In terms of the response, I think you brought up a lot of the key, attributes that have really supported it. First, I think you highlighted the strong community academic partnership, and I think that has been a critical part of our response to HIV, around our STI response, sexually transmitted disease, tuberculosis, as you mentioned that. I think, and part of that is our data-driven approach. I think using data to identify where the gaps are and for us to be able to focus our efforts in a very targeted way has really been an important part of the strategy. And a good example of that is our testing strategy. So knowing, I think you've already shared, we're very fortunate in San Francisco. We have one of the lowest, if not the lowest, mortality rate from COVID-19 of any jurisdiction in the United States. We also test more than any jurisdiction in the United States. Currently, our testing averages, you can go to our website and look, all these data are publicly available, ranging between 7,000 to 8,000 tests per day here in San Francisco. That's a 7-day running average. And using testing, not just doing overall, kind of offering testing, but targeting testing specifically to those neighborhoods that have been disproportionately impacted by COVID, in particular in the southeast sector of the city, and particularly in the Mission, in the Tenderloin, et cetera. These are communities that have been particularly hard hit by COVID. So I think that's an important part of this strategy. In addition, I would say, and I think we talk about HIV, we talk about the San Francisco model. And what's key about the San Francisco model is it's a community response. It's really a collaboration between public health, academia, and with community partners, with community input to telling us, here is what we need. Here are the gaps. Help us try to address those gaps. And doing that in close partnership, it's been critical around our HIV response, and it's been absolutely critical for our COVID response. I think you're on mute, John.
Yeah, it's fascinating. I mean, it just, it really highlights, I think, how at the time when I think the federal authorities, and even maybe a little bit at the states, who feel pressures economically and from politically and other things, have sort of eschewed, I think, data-driven approaches to the pandemic. We in San Francisco have remained absolutely laser focused on data, which I think is in part what we'll talk about when it comes to what drives the vaccine response here in the city. And I think, again, it's great to have truly, I mean, people like you trained both in epidemiology and in public health, as well as in soundly rooted in medicine, being able to give these really informed, data-driven decisions, and put them into play. I think it's made a very, very big difference. You in particular, right, were involved in setting up the housing program in the city, the temporary housing program and COVID sheltering program, which I can tell you from my inpatient duties in the hospital, dealing with not only with the susceptible population admitted to a hospital during the COVID pandemic. This has been invaluable to us. I mean, it's kind of stunning. We've had a few incidences of COVID breaking out in homeless shelters and things like that. But given the size of the homeless population here and the promiscuity of contact between the unhoused, it's remarkable how well controlled the pandemic has been. Can you talk a little bit to that? Because I think that's a unique part to the San Francisco response.
I appreciate you saying that. I mean, it has been, I think it was March 16th when the shelter-in-place order was released by Mayor Breed, and in collaboration with the number of counties across the Bay Area. 3 days later, we launched our first isolation and quarantine hotel. And that was in response to two things. One, we recognized people who were unsheltered would not have an opportunity, and those who were sheltered would have a hard time in a congregate setting, isolating if they had COVID or quarantine if they'd been exposed. And so we needed a different strategy. And so we, San Francisco and a number of other jurisdictions started looking at alternative arrangements, hotels being one of them. So on March 19th, we launched our first hotel, and then over a period of 2 to 3 months, had up to 5 hotels, over 500 beds that we're able to offer folks if they needed isolation and quarantine. So one is to help to contain the response, contain COVID in the, people experiencing homelessness. But the other major issue was what we saw in New York City, what we saw in Italy early during the pandemic, is those health systems were overwhelmed. And given that about a third of the admissions to Zuckerberg San Francisco General Hospital, our largest county hospital, are among people who are experiencing homelessness, we knew that we needed to have an alternative place so that our hospitals wouldn't get impacted if in fact that surge in cases were to be realized. So in part, it was a two-pronged strategy, is to preserve capacity in our hospital and also to make sure that we were providing safe places to prevent community transmission in people experiencing homelessness.
Yeah, it's truly been a remarkable program. I can tell you, it's notoriously difficult when someone who's unhoused has to, leaves the hospital but still has ongoing medical concerns. Where do you put them? We have something unique in the city called medical respite. We have, obviously, a skilled nursing facility that's city run, which is also unique to San Francisco. But there's a huge number of people that are unable to go to either one of those places for a variety of reasons. And so to have a place for them to actually shelter during the pandemic has been invaluable. I can't tell you how important that's been. So with that, I'm sort of move on to a couple of spots. A lot of people keep flying into the Zoom program here, left and right. Are here, of course, to hear about the city's vaccine response, which I think sort of follows along the lines of what we've just been talking about. The San Francisco, again, by many different metrics, even given the vaccine supply issues, has been, I think, ahead of the curve in a lot of ways at reaching out to the community, particularly the vulnerable areas in the community. And getting people vaccinated. It's been a remarkable program. I've witnessed it personally from my own office door, where outside there is a line of people going around the block coming in to get vaccinated, basically right next door to me. It's been really remarkable. I thought maybe you could share a few slides and talk about a few questions that we sort of had in general. One, where does the vaccine come from? It comes from the federal government that buys the vaccine, and then it gets to the state. And then I assume the state decides which counties can have which allotments. So how does the city then decide how it gets distributed from there on out? And how does the city even know what it's going to get week to week in terms of number of vaccines and which vaccines it gets, and decide where it goes depending upon how that irregular supply actually comes in? How does the city balance equity making sure that there's obviously competing interests, right? There's equity can be which patients are more vulnerable to severe COVID-19 disease and maybe should be immunized first. Maybe there's which proportions of people are disproportionately affected and maybe should be vaccinated first. Which people are the super spreaders, which in terms of just pure pandemic numbers, you figure you want to vaccinate to prevent further spread of the pandemic to the broader population as well. And then, and most importantly, just talk about some of the practical aspects. Even if you have vaccine and even if you know you need to get it into certain communities, how do you physically set up the ability to put vaccine into people's arms? Do you rent a convention center? Do you go into neighborhood communities and go to knock on the local churches and set up little vaccination centers there? How do you make sure there are enough syringes and people and capacity to put the vaccine into people, even if you happen to have it?
Great questions. And I'll try to cover that with some of the, I put some slides together, as you mentioned, and I'm happy to kind of provide a little bit of that background and talk a little bit about allocation. And we'll obviously during the Q&A, we'll try to answer many of the questions. I think you've really provided a great lead in here. So what I'll do, just to give you a brief overview of vaccines, I'll talk a little bit about the distribution process, the points that you made about pathways, the phases in terms of, you've heard about phase 1A, now moving into phase 1B, and what does that mean? And then our Department of Public Health, and CCC stands for the COVID Central Command, which is our organizing structure for the COVID response in San Francisco. And then talk about some of our accomplishments and challenges. So I think first, just in terms of a vaccine, when we think about vaccine, and actually my background, I come after I finished training, John, after we finished up in residency, I joined the health department, and my first role was really to oversee our HIV vaccine clinical trials program. So I feel like I could have used the same slide, for an HIV vaccine talk, and I'm using it here, to talk about a COVID vaccine. But ultimately, we're hoping that a vaccine is going to benefit the individual, right, by reducing the severity of illness and hopefully preventing infection. And then ultimately, we want to benefit the community by reducing transmission and ultimately having healthy communities. The vaccines that we have currently that have received emergency use authorization can reduce the severity of illness, actually quite well, remarkably well. And so that's important. And there's still questions about their ability to prevent asymptomatic transmission. We know that, more than 40% of transmissions are happening from people who are asymptomatic. We still don't have the answer to that question. And there's some very helpful clues to think it may be helpful, but we don't know the answer to that question. But ultimately, we do know that these vaccines can reduce the severity of illness. And if there's ever a chance to use it to share an electron micrograph, I'll be happy to do it. So here you go. On the left is the coronavirus itself. That crown, that's what corona means, right? Is the crown. It's a circle of light of these spike proteins that surround the core of the virus. And it's those spike proteins that all of the currently the approved vaccines develop immune responses against. And I love this image, which really shows the spike protein. And then what this spike protein does is it links on to this human receptor called the ACE2 receptor in the body. And through that linkage, almost kind of a lock and key, allows the virus to then enter the cell. And then what we're trying to do with the licensed vaccines that we have, or those that have received emergency use authorization, is basically to develop these antibodies that attack parts of the spike protein and prevent it from entering the cell. And many of you have probably seen the New York Times has this coronavirus vaccine tracker. Currently, as you know, we have 2 vaccines that are fully approved for use here in the United States, and that's the Pfizer vaccine and the Mrna vaccine. And then we do know that Johnson & Johnson just submitted their package to receive review and hopefully approval of their vaccine, and that the FDA will be meeting on February 26th to review that. And just in terms of the 2 vaccines that are approved, the Pfizer and the Mrna, they use what's called the messenger RNA technology. And very exciting are the first 2 vaccines that have been approved using this technology. And research has been underway for quite some time to look at this strategy. And it's an exciting one because what it basically does is it uses a little piece of the virus. This is not a whole virus. It's not live. It's not weakened or killed virus. Just uses a part of the genetic sequence that codes for the spike protein. that little piece of genetic signal is very unstable in the body. So what they do is that they wrap around this lipid coating, and that's given as an injection. And essentially what it does is it directs cells to produce these spike proteins. And then basically the body remembers what those spike proteins looks like if it's exposed to coronavirus. And then with that robust antibody response, protects us from severe illness. And we're hopeful that will protect us as well from infection. And in terms of the phases of vaccine rollout, it's important to state that California, I think as you alluded to this, John, that the federal government gives vaccine to the state of California, and then the California needs to allocate that vaccine and does this in a phased approach. Right now, we're in a period of very limited vaccine supply, and as a great example of this past week, we received an allocation of 13,500 doses, and the Department of Public Health receives only about a third of the vaccine. The rest of the vaccine goes to what's called these multi-county entities. Kaiser, Sutter, et cetera, get their vaccine allocations. So, but our ultimate goal is to vaccinate 10 to 15,000 people per day. We receive 13,500 vaccines for the week. So again, we have a supply issue. And so, but with limited supply, there needs to be a tiered or phased approach in terms of its distribution. So the current state is that we are allocating vaccine to phase 1A, and I'll talk more about that in a minute, and in people 65 years and older, with those over 75 having the highest priority. And our future state, once we have a number of more doses available, is to really make vaccination routine across the population. The reason why we're focusing on people 65 years and older is really, I think, highlighted in this graph to the right, which basically shows that about 83% of the deaths have been identified in those people 65 years and older. So that is clearly an important priority population. And then when we talk about phase 1A, we talk about 3 separate tiers, and you can see them here. Individuals who are working in acute care, John, working in the hospital, skilled nursing facilities, paramedics, EMTs. You'll see tier 2 also include public health field staff, community health workers, those who are working in home supportive services, and then a number of other groups in tier 3. So that's our current state, and we'll talk more in just a moment in terms of where we're going to be moving. And in general, we've seen that in San Francisco, about 80% of our healthcare workers have been vaccinated, and about a third of those individuals over the age of 65 have been vaccinated. So that's our current state. Where are we moving? Just yesterday, our mayor announced that San Francisco will be moving into phase 1B, tier 1, as of February 24th. And so that includes, again, individuals 65 years and older, as well as those who are at risk of exposure at work in the following sectors: education, childcare, emergency services, and food and agriculture. And there are a number of other tiers that are listed here, and you can go learn more about the tiers and the system at the website that I've noted here. But it's important to say that we still need to get additional guidance about that rollout for this group of important frontline workers. So in terms of the vaccine distribution process, there are kind of 3 core or key guiding principles. Equity, and you've kind of highlighted that, John, in terms of how that can be expressed. Speed, and then partnerships, because we cannot do this alone. The health department alone can't do this alone. We need to do this in collaboration with the larger health sector, as well as with community. And so we need to ensure that there's capacity to fully use the vaccine supply that's aligned with CDC as well as state guidelines. We need to ensure that there's equitable vaccine allocation and administration, particularly for those who are at highest risk for morbidity and mortality from COVID, as well as those communities that have been disproportionately affected by COVID. And a great example of that, unfortunately, the Latino community here in San Francisco, which makes up about 15% of the population, over 40% of the cases have been seen in people in Latino residents. So we have a specific commitment to try to ensure that those populations that have been disproportionately affected have ready access to vaccine. We need to prioritize rapid vaccine access, as I mentioned, and particularly those who do not access healthcare. Even though our insurance rates are high in San Francisco, we have a large number of people who are undocumented, who do not have publicly available insurance. And so we need to make sure that vaccine is accessible to those residents as well. And that we need to be tracking the strategy, providing metrics, and reporting on our outcomes. And in terms of our overarching vaccine strategy, we have three main core pillars of this. First, the high volume vaccination sites. And so you've probably heard in the news, there is a site at City College, there was a site that just opened this week at Moscone, and there will be a third large volume site at the San Francisco Produce Market in the Bayview. Then another main area or pillar is community vaccine access sites. So these include our federally qualified health centers, a number of our clinics that the San Francisco Department of Public Health supports, like clinics based at Zuckerberg San Francisco General Hospital, at our Southeast Health Center in the Bayview. We also are establishing new sites. So for example, in the Mission, just this past week at 24th and Cap Street, we created a new site in collaboration with UCSF and the Latino Task Force. And then we also anticipate that there are people who would find it difficult to get out to one of these sites. And so we need to bring vaccine to them. And so we are mobilizing a mobile vaccine strategy. And then finally, the last pillar is pharmacies. Pharmacies are going to be critical, both the retail pharmacies as well as community-based pharmacies. And again, our goal is to facilitate 10,000 vaccines being delivered per day. And this is a complicated map. It just shows you all of these different types of sites. I talked about the high volume site. Healthcare systems, your own private providers through Kaiser, UCSF, Sutter, Dignity are going to be providing vaccine. And then the San Francisco Health Network, again, the Department of Public, that sits within the Department of Public Health, the neighborhood sites, other sites that they're being offered. And then in collaboration with Safeway in San Francisco State, there's another site that's going to be available, vaccinating people over the age of 65. And we'll be doing that during February and March. Number of challenges, though, as I've already talked about supply, but clearly there's no unified federal or state system for vaccine delivery. We're hopeful with the new administration that there will be more work in terms of the plan and rollout around how the coordination will work. But again, that's an ongoing, those are ongoing efforts. We're unclear how much vaccine will be allotted and when, and it's that unpredictability that is a huge challenge. And because we are trying to promise vaccine to different groups, at least the vaccine that we have auspices over, it's really important to know that there's still quite a bit of unpredictability. The state and federal guidelines are evolving, as I've mentioned, in terms of data quality and consistency, and timeliness of the data that we get from the state has varied. And then counties are moving at different speeds. And a great example of this, in San Francisco, we are fortunate. We have a very large healthcare workforce. Either people who live here in San Francisco or come from out of jurisdiction to work here. Because of that, it's taking us longer to be able to vaccinate that population. In other counties, they have a smaller number of individuals who are healthcare workers. So that's just one example of why there's been variation. And then a number of important operational considerations. We know one of the vaccines, the Pfizer vaccine, requires ultra cold temperatures. So we have to schedule two doses. They're 3 to 4 weeks apart, and the storage requirements that I've just described. So I think we are on our way. We're moving forward. These are data as of today. Looking at the doses, if you look to the right, over 144,000 doses that have been administered in San Francisco, 109,000 first doses and about 34,000 second doses. To the left, you can see those, and that to the right is people who live in San Francisco as well who work in San Francisco and from out of jurisdiction. To the left are those who are residents, people who live in San Francisco, 101,000 individuals who received their first dose, 27,000 who've received their second dose. And you see that percent of over 16 population have received at least one dose. That's at 13%. We still have a lot of work to do, but we're making some inroads. And again, with vaccine supply, we have the distribution system in place in order to get shots in arms. If you aren't already, please go to this website, the Get Vaccinated Against COVID-19. And the website is noted there at sf.gov/getvaccinated. And then there's additional information available on our website. And we'll talk more about distribution. I'm happy to answer questions about that as well.
That's simply fantastic, Jonathan. That's just summarized so beautifully. And I guess one question that sort of Jessica was mentioning, or to me, that you answered there, I think on your last slide, but my parents who live in another state on the East Coast, in their 80s, have found it impossible to get vaccinated, in part because my parents are very old school, and they still see a private practice doc, solo practice kind of guy himself near retirement, who's not affiliated with an ACO, accountable care organization, or any large healthcare system. And so, they registered with their county, but beyond that, they don't have a UCSF or a Kaiser or a Sutter to basically, search their electronic health records, identify them as in that tier 1A, and notify them proactively to say, make an appointment. So people in San Francisco who sort of fall into that range as well, who are not, patients in the public health system, and maybe who don't belong to One Medical, or haven't been seen at a Sutter physician, or how do they go about? Is it they go to that website, get vaccinated, and then they put their information in, and the city will proactively say, get vaccinated. Maxine Hall has availability for you right now, or the San Francisco General, and we'll direct them to one of those places?
That's exactly right. And people, you should still try to work through your private provider, because we do have separate allocations for larger private providers, not outside of the multi-county entities like the Kaisers and the UCSFs. So that there are ways for you to be able to get vaccine from providers. And again, we're at a supply issue. So the more supply we get, I think it'll be a lot easier to be able to get vaccine that way. But again, I would recommend everyone to go to that website, be registered, so that when vaccine is available through either our high volume sites or some of the other sites that I mentioned, then we'll be able to increase access.
Oh, that's terrific. And so, are you having Walgreens, for example, deliver? Because a lot of these large doctor groups don't have a -80 freezer, for example. So, is there sort of mobile delivery to the nursing homes and to these large practices where they're then administered on site?
Yeah, so the federal, as you mentioned, a lot of the vaccine comes through the federal partnership. So for example, the VA received its own allocation. And so for people who are veterans, they're able to go through the VA and be able to get access to vaccine. That's a separate allocation. A number of the larger retail pharmacies also received a separate allocation, and specifically charged with helping to vaccinate people within skilled nursing facilities and other residential care facilities. So that process is underway, and that's separate from our allocation. But you're absolutely right that the facilities for some of the vaccines, like the Pfizer, would need to have a -80 freezer. So we have to work out complex distribution patterns to get vaccine for the places where it's stored safely and then distributed to those partners. It is complicated.
Well, it really is, to say the least. There've been a lot of questions sort of asked along the lines of sort of what the city's doing in terms of vaccine administration and vaccine surveillance. One particularly great question that was asked is the city actually monitoring the safety and efficacy of the vaccine and the reduction in COVID-19 infections in real time, sort of in our city population? Is there sort of like a phase 4? I know there's a vaccine reporting network and things like that, and the ongoing Pfizer and Mrna studies are following patients out to 2 years, for example. But are we doing real-time data to follow up? If someone's admitted with COVID, for example, to the hospital, do we know whether that person was vaccinated or not, and therefore know something about the effectiveness in the real world?
Yeah, it's a great question. So I think in terms of we're relying on a lot of the systems that are in place, that CDC, VAERS, to be able to look at side effects from vaccines, et cetera. So we're reliant on those large systems, and probably because of the vast number of people who've been vaccinated, that is, and will continue to be vaccinated, I think that will be an important data source around long-term safety for the vaccine. I will say that we are looking, and as you can go to our website, look at our case rates and be able to see, and we are trying to project and model, looking over time with as increasing numbers of people in specific groups are getting vaccinated, what is the impact on cases? I mean, the data out of Israel is actually really quite striking. As you see, they've vaccinated, over a third of the population, almost everyone over the age of 65, and they are seeing a dramatic drop in the number of cases. They've seen over 40% drop in cases and a 30% drop specifically in hospitalizations for those over the age of 65. So these are exciting data. we're tracking our own data. And then again, in hospital, I think as you're mentioning, John, is that fortunately for people who, within system, if you're you can go to your electronic medical record and be able to see, did you get vaccinated? And then looking at some of those patterns. So I know that work is underway at a number of the health systems around the city.
And then I'd be remiss if I weren't here as part of a gathering of the Sheriff Israel community and stuff. There are a lot of questions that have been asked about what's the future for public gatherings in the vaccine era. And what's it going to take to bring people back together again, to come to synagogue, to have bar mitzvahs and weddings and things like that. Do you foresee that there may be that the infection rate has to drop below a certain, or the prevalence rate has to drop below a certain level, or the R as they call it, infected rate in the city below a certain level, or are people going to be required to show vaccination cards, for example, to get in as well, like your yellow fever card before you can enter a certain country or whatever? How do you foresee this evolving over the next 3 to 6 months, or if there is a way to even know?
Yeah, it's hard. It's hard to. There's a lot of discussion about all of those scenarios that you just described, but we haven't set any particular thresholds about certain, like a prevalence in the community to decide what that guidance would be. At the current state is, even with folks who have been vaccinated, because we don't understand whether or not the vaccine has an impact on transmission, we are recommending that people still take the careful precautions around masking, social distancing. As more data are revealed to us about these vaccines and their ability to prevent asymptomatic transmission, I think that that guidance may change. So we're tracking that very carefully. At this time, though, we're taking a more prudent approach, given that we still lack a lot of information that we need in order to make those recommendations.
So I'll move on to some other questions that have come in throughout the week. Some of these are a little bit specific to the vaccinations themselves and to the immunology of the vaccinations and stuff like that. So maybe I'll sort of repeat the questions that have been sent to me here, and then you and I can take stabs at whatever we choose to take a stab at if we want. I will say this, there's been a lot of concern about the emergence of new viral strains and the effectiveness of the vaccines as they exist today. I will start by saying a couple of things. I think, and there was, of course, a disturbing article in the Washington Post today about South Africa basically abandoning the AstraZeneca vaccine, which is not approved yet here in the US, because there's such a large prevalence of the South African variant in that population, and the vaccine appears to provide no protection against at least acquiring the infection. But you brought up in your slides, Jonathan, that what these vaccines really appear to do better than anything else is prevent severe complications of the disease, particularly in the most vulnerable people. And that's in fact thought to be not just an antibody-mediated response, but a reflection of people's T-cell responses. So even if the spike protein is mutated in such a way that the antibody responses may not be the most effective with the new strains at preventing actual infection, there's still very good reason to believe that T-cell responses, which have the ability to be a little more broad-based against viral targets, might be able to do the heavy lifting in preventing severe COVID-19. And so once someone is infected, and I don't want to get into the specific details of how that immunology works, but there's good reason to believe that. And furthermore, the mRNA vaccines, really what makes them unique is that you have the ability to tweak the mRNA sequence very easily in a matter of basically a few days, and then can have it produced and tested in very, very short order, the way that you can never do previously for vaccines. It's what this technology is tailor-made to do. And there's even talk from Mrna, for example, of having a booster component to the vaccine come out for some of these newer variants in the very near future. So very, very excited. So I know people are worried out there, but continue to get vaccinated anyway. There's nothing that you could do that's more important, I think, right now. Don't worry about the new variants that are out there. Continue to get vaccinated. Your thoughts, Jonathan, at all, if you want?
Completely agree. Everything that you just shared. In addition, I would add, even with the J&J vaccine, it was tested in South Africa and still high levels. I mean, again, we haven't seen the published, it's like a science by press release at this point, but until we see the actual data, but at least what was reported is that even at those sites there, the efficacy was incredibly high in preventing severe disease. So I think for all the great reasons that you just described, we have a rationale that these vaccines should still be protective, even if the efficacy rates are lower somewhat, even with the high protection that we're still seeing to prevent severe symptomatic disease, it's still highly encouraged. So yes, absolutely get vaccinated.
We've had a lot of questions from the Krasny family, don't know if you know Leslie Krasny and Michael Krasny, as well as from Gordon and others in our community that generally have asked the same thing. This is not the exact question that you're asking, but it's a summary of many different questions to basically say like, how do we know that the vaccine is 95% effective? What was actually studied? And so what I'll say is this: you have to be very careful. What's amazing about these vaccines is, for the first time in my memory, the protocols for these particular vaccine trials have actually been published. And so you can actually, just like the FDA, usually the FDA gets this deep granular information, but the public doesn't. But for the sake of transparency, a lot of the way in which these trials were conducted has been publicly released, and so there could be a lot of scrutiny into these trials. And so the way, for example, I'll speak to the Pfizer vaccine specifically. The way Pfizer demonstrated its primary outcome was basically in, I believe, in laboratory test confirmed COVID-19 infections. It didn't discriminate between whether or not patients had severe infection or not. It's patients who actually had a PCR positive test with symptoms, CDC symptoms compatible with COVID-19. That's what was reduced 95%. I think there were like 100 and something cases in the placebo group and like 7 in the control group. It was a remarkable reduction. And there were several secondary endpoints that were looked at as well, which included symptoms of COVID-19 not confirmed by a laboratory test, severe COVID-19, and there were criteria for that as well. And the vaccine was remarkable in basically eliminated almost completely severe COVID-19 in the vaccinated group versus the placebo group as well, from like 5 or 6 cases down to like 0. So, I think when Gordon and others sort of out there asking about, what does the vaccine efficacy really mean? That's what we're talking about when we're talking about the tremendous efficacy as well. I know you know the data a little bit better than me, probably, Jonathan, but is that pretty accurate? Or
summary? Absolutely. And then I would add to that, in the question, because what people are asking is, well, we don't know yet whether it affects asymptomatic transmission. How would you figure that out? One of the ways would be is that in those individuals who've been vaccinated and potentially continue to be exposed to the virus, is to be able to do serial testing in those individuals to see if you still have detectable virus. So those studies are underway, and we hope very shortly we'll have some additional data that'll be able to support the idea that these vaccines can be protective against asymptomatic.
Yeah, and this is an example of, like, you guys obviously can't see it, but this is a layout of the study visits for the Pfizer trial, and you can see what was collected at each visit. And what they did not do in the trial is do serial nasal swabs on everybody at every visit, right? They had a nasal swab looking for the virus at the time they received the first and second doses of vaccine to ensure they didn't have COVID-19 at that time and weren't going to be sort of false positives. And then you got a nasal swab only if you were symptomatic thereafter. So there wasn't the routine tracking of patients to see if there's asymptomatic transmission. And that's really only something that can be answered at a large scale post hoc, I think, analysis, just like what you said of the population of people where you have known infections within a vaccinated population. How do you see the transmission, sort of progressing at that point? That's my understanding, pretty much the best way to do it. And that's something you really couldn't answer prospectively in an approval trial as well. So there's a nice question, a very complicated question. Gordon sort of dumped on me from a nice comment, who basically said that their son had been reading a lot about this, and is there concern for something called antibody-dependent enhancement with these infections? And that's a very, very fancy, complicated immunologic term that really hasn't been appreciated as an entity until the last few years. But basically, it's a good question because it's a real question, and it was specifically thought of as an issue when the vaccines were developed. So it's actually a very, very, I think, very thoughtful and prescient idea. So what is antibody-dependent enhancement? Well, there are some infections like dengue fever that people have noticed for a long time that the first time you get dengue, if you happen to live, say, in South America, you get a significant illness, but it's not a critical illness usually. But the second time you get dengue, it can be a wallop of an illness. And nobody has ever really understood why that is. Usually when people get infections the second and third time, it's less severe because your immune system has developed a specific response that tampons down, a recall response that tampons down or eliminates illness the second, the third, and the fourth time, unless the virus or the pathogen somehow evades immune detection, like influenza can do by changing its surface molecules and stuff. So in dengue, that's not the case, and patients can actually get worse disease the second time. And it turns out that if you make an antibody response to an infection, a viral infection like dengue, And the antibody response is not high enough to prevent the infection from entering your body, but it's enough nonetheless to still encounter the virus, that it's possible that certain cells in your body, which have the ability to take up and have receptors for antibodies, can actually bring the virus into those cells at an enhanced rate, and it can propagate the infection paradoxically, even worse. That's something that's not seen with a lot of infections. There are other reasons why having an antibody response can make an infection worse in terms of how the immune system is activated. It's not seen in a whole lot of infections, but it is seen in dengue, and it's a theoretical risk. With the initial SARS virus 20 years ago, there were some animal models when they were trying to develop a vaccine to that suggested there could be antibody-dependent enhancement of the original SARS. And so when these vaccines were developed for SARS-CoV-2, which is this coronavirus, which is closely related, there was a specific concern about if patients are vaccinated to this infection and they make antibodies to it, is it possible those antibodies could actually enhance a real infection should somebody get it post-vaccination? And the short answer to this is that was a specific adverse event outcome that was outlined in the clinical protocol for the study. So they have been looking for this, and it has not been found. The flip side of that is that, this is still relatively new stuff. It isn't like they have 20 years of experience to see in millions of people to see whether that actually ever happened or not. But it doesn't look like either in the clinical study or in post-study surveillance that there has been that reported. And it's a very distinct kind of syndrome when you see it. So a very sophisticated question. I can see why some people might be concerned about getting vaccinated, but the companies are well aware of this, as is the NIH and others, looking for this, and they have specifically looked for it and not found it to date. Nor has, by the way, has this been found in the natural infection with the SARS-CoV-2 coronavirus. Anything on your side of that?
I think you answered. Yeah, no, I completely thank you for that.
I just want to make sure.
Great explanation.
I'm not stepping on any, not making false statements here or whatever. A lot of people are asking questions about what medicines can they take around the time of the vaccine. Can they take their pain relievers prior to being vaccinated? Should they hold them when they're vaccinated? If they are vaccinated and have a response, can they take Tylenol to treat the fever or not? And the short answer is, yes, you can take pain relievers. We don't know, in all honesty, how, especially pain relievers that are called non-steroidal anti-inflammatories, can affect the immune system overall. It's conceivable, and it's been suggested in weak vaccines that maybe you can dampen the response a little bit. But in the clinical study, first of all, these vaccines are extremely immunogenic. They're compared to like your standard influenza vaccine. These generate immune responses that are like revved up machines compared to like the slow jalopy that like the influenza vaccine sort of, for example, does. So it's not really felt that like, your naproxen is going to have a major effect on this. But the clinical trials did allow people to take non-steroidal type drugs and antipyretic, anti-fever medicines if they happen to have a flu-like reaction to the vaccine. And again, you can see the efficacy results, I think, speak for themselves. Your recommendations, Jonathan, at all, or that's my general gestalt from the.
Yeah, our general recommendations is we don't suggest that people pre-treat with any type of antipyretic or non-steroidal anti-inflammatory. But if you're having symptoms after you've been vaccinated, take a Tylenol, take an ibuprofen. We don't anticipate that there'd be any issues there. We recommend that because no one should feel feverish or chills and have to. So please do.
And some of the reactions are real. Someone wrote a question in the chat saying, "Hey, I got the Pfizer vaccine. I had no reaction. I'm worried. Is that bad or not?" And I can tell you, if you look at the Pfizer clinical trial, there are plenty of people in it who did not have a sensation that they were having this flu-like response to the vaccine, and their immune systems were just fine. It looks like, at least in terms of the trial, and the vaccine was still very, very efficacious. There are other people that are saying, like, geez, I've heard that the Mrna vaccine, especially with the second dose, induces a wallop of an illness compared to the Pfizer vaccine. And I don't know. I mean, certainly the vaccines are very similar. They both have mRNA. The mRNA has been modified a bit to make it a little less immunogenic, ironically, because RNA itself can be very, very stimulating to the immune system. And so they want to sort of tampen that down just a little bit. But the lipid components are a little bit different in the proprietary shell that surrounds the mRNA. So it is conceivable that some people are having more aggressive immune responses or not. personal experience has been almost everybody, most of my nurses who got the Mrna vaccine at my clinic at the General have ended up out for a day or two after getting their second dose because they've had a fever or bad muscle aches or things like that. And then they come back to work saying, I got a great immune system. This is awesome. I had no response to the Pfizer vaccine. I felt I had a dead arm for a couple of days. So who knows? But I think everybody is getting great immune responses regardless. So don't worry about the side effects of the vaccine, right? I mean,
Agreed.
Okay. We have a question here from Kathy Taylor saying, I was told that this is a non-live vaccine as opposed to polio vaccines, so they are less dangerous, and that's why they were developed faster. That's actually correct, Kathy. It's actually, she's messaging me privately. That's correct. They're not, Jonathan went into a beautiful description of how these are not live vaccines. The Johnson & Johnson vaccine that's now in front of the FDA is a live vaccine. It's not the coronavirus. It's a wolf in sheep. It's a sheep in wolf's clothing, I guess is the way to put it. It's a kind of harmless adenovirus that's been manipulated to express that spike protein. But that virus is supposed to not be able to replicate. It's been neutered essentially. So that's a living virus. There's still, I think, will be some concern about if people have really weakened immune systems, giving them a live virus. But from all intents and purposes, it looks like this vaccine is as well going to be fairly safe. Is that right? You probably know more about this than I do.
Yeah, the Ad20. So it's adenovirus. So there are lots of adenoviruses. They cause conjunctivitis, common colds. I think there are over 50 serotypes of subtypes of adenovirus. This one is called adenovirus subtype 26, and it's been neutered. I think, as you described, it can't replicate. It basically can get into the cell, deliver the message of what the spike protein looks like, and then it's done. So it's impossible to get an adenovirus infection from the virus, from the vaccine, and it really is just a delivery vehicle, essentially, for the key message to tell the body what spike protein looks like, so you can develop an antibody response around it. So exactly the same. If not, it's impossible to get infected with coronavirus by getting a coronavirus vaccine. Similarly with adenovirus as well.
So we have that's a great answer. There's a question here that says, is the vaccine considered safe for pregnant women?
Great question. So none of the clinical trials enrolled pregnant persons. But we have very good reason to believe that the vaccine would be safe in the population. And the major reason why that is because the vaccine, when it delivers that genetic material into the body, it doesn't go into the nucleus. It doesn't enter the DNA. It doesn't affect the body's DNA. It just basically uses the body's kind of protein making machinery. By that genetic message comes in, and then basically the body creates these proteins. In no way does it affect the DNA. So we don't believe, so if someone is pregnant, it should not affect them, nor should it should affect the developing fetus. In addition, we're also recommending that women can breastfeed afterwards, even if they've been vaccinated. So I can't say that we have definitive evidence based on safety, based on prospective clinical trials, but we have very good reason to believe that the vaccine would be safe in that population.
That's that question's been asked to me a lot in clinics, especially can I breastfeed and not. And I think the description about that this is an RNA vaccine is so important. There are DNA vaccines actually that are being developed against the coronavirus, and DNA theoretically has the ability to get into the nucleus and to integrate itself into the genome in good places and potentially in bad places too, and then has implications for cancers and other kinds of things as well. But there's none of that with an RNA vaccine, and basically mitigates that completely. So that makes total sense. Vicky Keston wants to know, are there any updates on the next phases, like phase 1C, when they might be coming around? And was it possible that since this is such a moving target, that all may be thrown out entirely and it'll just be age tiers thereafter, or is it still going to stick to the components of phase 1C?
It's a fantastic question. I just put this up here again just to show kind of what, again, and you'll notice, as it says here, is phases 1B and 1C subject to change, because there have been a lot of discussions at the state about moving to an age-based system. But we don't have that guidance yet at this time. And as I just shared with you, we just received guidance from the state and then released our guidance for phase 1B tier 1 that will start on February 24th. But the other tiers are noted here. Oops, sorry about that. And other phases are offered here as well. So I think the answer to that question is this structure exists, subject to change. And as soon as we have more guidance from the state, then we'll be adopting that in terms of our rollout plan. So stay tuned.
So, and the last question I'll read here on the chat, and then I think Rabbi Jessica has a question as well, is given all these new variants that are coming out, how long do we think it'll take for vaccines to adapt to the new variants, to the new viral variants that are sort of out there? And if we've already been vaccinated, will we be eligible for a booster, and how long will that take? I don't know the answer to that specifically. You may know, Jonathan, but I know Moderna has basically already started studying an updated booster for the, I believe the UK variant, and they're probably working on the other variants as well. And to my knowledge, they feel they can get it into people's arms within 6 months, which again, in the vet seems, oh my God, 6 months from now, but in like developing think about the HIV vaccine experience. I mean, these things have taken literally 10 years to come to. Adenoviral vaccines, mRNA vaccines, these have never been done before. And to have this all come to market within a year is just staggering. It's really, in your career, this is what you've done for a living. Can you imagine you ever would see something like this?
It's extraordinary. And nothing else to add in terms of the variants. I agree with you in terms of that potential timeline to try to get a potential booster or other modifications that could be made. But I think it's just taking a moment, and it's extraordinary what science has developed in such a relatively short period of time. No steps were skipped, and I think that's a very common question. Were things done in a haphazard way, or because it went so quickly? There was a lot of work on these types of vaccines for years after the first SARS virus was identified. And so we were able to capitalize on that testing technology and that vaccine technology, and all that was learned that was immediately applied for the SARS-CoV-2 virus. So I think it's an extraordinary achievement. There are other products that are, obviously being evaluated, and we hope will enter the pipeline. But it's an exciting time for the science, and for us now, our real challenge is, around distribution and making sure that we are able to get vaccines to people so that it can help protect against disease and hopefully transmission.
I got to say, like, what you're doing is really remarkable, Jonathan, both proactively in sort of getting the vaccine to the areas in a data-driven way where it's really needed, and also in terms of surveillance. Because again, a lot of the questions that have come into us have been along these lines, such as, are you tracking how well the vaccine not only prevents severe disease, but moderate disease, and whether or not if you have the vaccine and you get moderate disease, can you still spread it to other people? People have been asking these questions left and right, and we won't know the answers to all of these because the clinical, until we look at how our real world population is behaving, because these were not primary endpoints in the approval trials. The approval trials were really focused on reducing symptomatic test positive COVID in people, and in secondary endpoints, looking at severe COVID versus not at 7 days post-vaccination, 14 days post-vaccination, 1-2 months, post-vaccination, those kinds of things. So with that, Rabbi Jess, do you want to ask another question? And let me just mute my computer so you can.
This is fascinating. I have two questions based on things that you were talking about. First of all, with regard to supply being so limited, as you're describing, there are people in the age categories that have been allowed who have not managed to get the vaccine yet. And we've been hearing that a lot at the synagogue as we're working very hard to check in with people and see how people are doing and see how we can help support people in their own, isolation, and also to come back together as soon as possible. What do we do? I mean, people who are in the allowable age category but aren't able to get the vaccine because of low supply, what's happening and what's the plan?
Yeah, I get, so I want to just appreciate the frustration in terms of the supply issues, and recognize that I think the website that I offered and actually has been posted to the chat. So please take a look at that. Make sure you're registered to get notified, so when you are eligible, the sites that have been established, particularly the high volume sites, are focusing on individuals over the age of 65. So, just again, it's being steadfast on your, online, looking for appointments to be able to come in. And I can say that people have, with some of these high volume sites, have had a very good experience They're relatively high throughput with, and the waiting times have been relatively short. So just keep your eyes on those sites. And I think having friends and family that are also helping you to kind of monitor those, be in touch with your providers. And if you are a patient in one of these large systems, whether it's UCSF or Kaiser or Sutter, they also have their separate allocations outside of the high volume sites that are really a collaboration between the city and those systems that are agnostic. For example, Moscone is co-run by Kaiser and by the city. You don't have to be a Kaiser patient to go there. So that it's really open to the city. So we have a variety of doors, and what we're trying to say, every door is the right door to try to get vaccine. Ultimately, it's about supply right now.
So register in multiple places and be patient. I mean, eventually, even as the phases continue to roll out, people from 1A, 1B, the 75 and over phase will continue to be able to get the vaccine.
Absolutely. Thank you. It's a great question.
Oh.
Yeah, so one thing I might suggest, Jess, that may be a good thing for the temple to do, since you're doing so much prospective outreach, there may be several congregants who might not be, in this age group, who may not be facile with the internet or be able to, schedule themselves online or things like that. It may be something for the HESED committee or other people to consider reaching out and offering assistance in scheduling appointments at these various centers. Maybe there could be several people who become experts in how to do this and can help congregants, both proactively or if asked to do it, help them register for vaccine appointments.
Great. I want to just ask one other question, Dr. Fuchs, based on what you started talking about, people in the city and the incredible work that you've done from the very beginning of this with the unhoused and also undocumented populations that are some of the most vulnerable people in our city and also some of the hardest to track, living in sort of dense situations. And what is the city doing to in a continued way, ensure that those people are able to get the vaccine so that they're not either at risk or, kind of part of a spreading problem as the tracking and sometimes the housing arrangements or the lack thereof of good housing or stable housing really contributes to an inability to find these people or to even respond, even if they do register. What is the city doing?
I mean, I think it's a great question. I think we're going to take a lot of lessons from our testing experience. And so the goal ultimately is low barrier. So people would be able to show up and be able to get vaccinated, and where it's community led. So communities that are trusted. For example, we work very closely with the Latino Task Force and have for many, many months, actually, since this last summer, to help establish testing there. They're low barrier. People can come. There are people who look like the community who are then inviting language concordance. So there's language accessibility, there's cultural concordance, there's all those things that we know are so important to make spaces feel safe and welcoming. And so we want to be able to rely on that very same strategy to ensure that the populations that are highly vulnerable, that are living in dense congregate settings, that are or who are undocumented, know that they'll be able to go to a place that feels safe, that they'll be able to get vaccine reliably. And I think that's a cornerstone of the approach. Ultimately, it's where we're going to go. Right now, because of limited supply and because of the vaccines that we have, it's a much higher barrier system. You have to make an appointment. So we are working on that. We have drop-in slots, for example, at Zuckerberg San Francisco General Hospital, at Southeast Health Center, specifically serving the zip codes and those populations that are disproportionately impacted. So it is part of the overall strategy. We recognize that we need to have low barrier access for folks to be able to get vaccine.
Yeah. I meant what I said about computer illiterate people and getting help for them, but maybe you shouldn't be the one helping them, Jess. Jonathan, thank you so much. This has been just an incredible discussion. We have an ongoing thing in the chat here, publicly and privately. There are people coming forward left and right to help our vulnerable population here navigate the website, the continuous refreshing that's required to basically try to get people registered for appointments. I think it's amazing how a great educational and informative program like this and the incredible wisdom that you've given to everybody here can now translate into even social action here within the Temple community. So Thank you so much for joining us today. This is, like I said, I have a tremendous amount of pride, both from our years together in training and a lot of memories from it. And I have even more pride now seeing what you've done with your career and your life and where it's taking you. And we are so lucky in San Francisco to have you and people like you on the front lines helping to navigate the city through this unbelievable pandemic.
I'm going to come over here so I don't get teased for being computer illiterate, as everyone in this community knows I am. But I just want to close by saying, not only saying thank you, enormously thank you for your time, but for your incredible leadership in the city. I said just before we came on, and I've said this to each and every one of the people who has come on to talk to us about the COVID situation, I feel so much better knowing that incredible, incredible people are working on a solution and working on supporting our city and our community. And I'm so grateful to you for your time, for your wisdom, and for your leadership in the medical community, in the Jewish community. And we hope that you will often come to visit us here at Sheriff Israel. So thank you so much.
Thank you. It's been an absolute pleasure and privilege. Appreciate it. Take care and be safe.
Oh, you too, Jonathan. Thank you.
Thank you all.
Thank you.
Bye-bye.
Bye-bye.